So over the past 48 hours, I would say, we've seen lots of the cases actually we had is dealing with the distal cap bifurcation. Distal cap or the bifurcation CTO is an important thing. It's as you've seen today and yesterday, is a frequent problem. You must be familiar with all the techniques and technologies of complex bifurcation treatment, including Dr. Hanratty technique.
Slow to take off.
But it happens, yeah. The bifurcation issues are important because if you lose a branch, it may cause procedure myocardial infarction, may result in incomplete revascularization. Bifurcation at distal cap is especially a challenge during antegrade approach, as we've seen in the case of today, and yesterday we did the offline. Retrograde approach may help to save both branches, but it's not guaranteed though. Reverse card may help to solve both branches, but again, it's not guaranteed as well. I share with you an example of a case. 50-year-old female had a non-STEMI prior to the CTO procedure. She had a PCR to her LCX. She has RCO CTO. She has no, I don't know why it matters. She has absent right radial pulse, normal ejection fraction, and normal biochemistry. So that's her angiogram of the lift system. Some diffuse disease on the LED, but you can see the RCA distally at the bifurcation. It's like a 0-1-1 bifurcation. When you do a dual injection, it shows it very nicely. Where's the pointer? And you can see the CTO is at distal bifurcation. And proximal cap is at bifurcation as well. So bifurcation, proximal bifurcation, distal. So in this, we went antegrade with the Pilot 200 at the time Corsair, with it then upgraded to Gaia 3rd. So we went up and down. So antegrade approach. Sorry. And then we reach the distal cap. Then we're able to go antegradely in the posterolateral branch, but we were not able to secure the PDA. So there comes the utility of dual lumen microcatheter. So we put the dual lumen microcatheter, tried to act as a PDA. And I think in this case, we we actually dissected the PDA. So what to do next? Shall we stent and say, have a good day, happy days? Shall we leave it and come back? Or shall we go retrograde? So we decided to go retrograde. Oh, sorry, so I'm just showing you the schematic here. When you have a distal bifurcation, so the wire went into the posterolateral branch by antegrade wiring. So maybe if we take another wire, we tried to do that with the dual lumen, that failed. So options are, where we dissected, we could have actually done a knuckle and take a stingray and puncture back in, that's an option. And the third option is to come retrograde. So we had an option actually to go antegrade dissection, re-enter the ADR into the PTA, which we didn't do. So we decided to go retrograde. And we got retrograde access with the, I think, sign black. Got into the PDA. So then we did retrograde wiring. I think at that time we used a Gladius. Went up. Externalize the wire. Stenting. And then we change all these wires over dual lumen antegradely. Take the guideliner down. Stent. And here again, This is integrated wire which was there from the beginning. So over the externalized wire, we use a dual lumen again and try to access a posterolateral branch. So they're all in the same plane. And then we did a reverse tap technique for that what matters. However, by doing this, remember we talked about, look what happens here. It's a guide, and then somebody injects, and this happens. Yeah. So what to do next? Number one rule. Something bad which you would say. You turn around and you can say it. Number two is make sure no one injects. So there's a reflexive mechanism that people try to inject every time, so that's a problem with just forceful injection. The guy dissected the cusp. So please,
helpful in that scenario, isn't it? That injection is adding health to the kids.
Nothing. Not at all.
It's made worse because of the balloon is extended, so it had to go back and do some damage.
Correct. So here, then is you want to finish the cases. Okay, we end up to look, because we haven't had a chance even to see what happened to the distal bifurcation now, because we stented the bifurcation, the mid-RC, you want to assess everything. So what do you do now? How do you assess that? You can use IVUS and assess the whole vessel. You don't need an injection, right? Or you can use
guideline and inject this thing.
Yeah, you can use it, take a guideline and advance it further in and inject, see what's going on distally. Sorry.
Take care of that one first.
So guideline was advanced, and then we were happy with the distal part, and we stented the ostium. Did the CT, everything was fine afterwards. The teaching, it's a distal bifurcation, but it's we talked about what are the why distal bifurcation is important. At the same token as the issue of complication. Number one rule is how you prevent complications. So be very cognizant about these things, because you spend so much time getting a fantastic result, and then you will be burned with a complication like this. And occasionally we've seen cases in which you dissect the whole cusp all the way to the aorta, and you have a type A aortic dissection, and could be very life-threatening complication. The distal cap bifurcation is very, very important. You will see it very, very commonly. You have to have a strategy, how you feel, how you deal with them. You have to know if very commonly when you have a distal bifurcation, it will be solved by a retrograde approach. So that's where you need to, this is how the planning happens when you do the case. Actually, a lot of the cases we did over the past 2 days had a distal bifurcation. You've seen quite a bit of them.
Ask you, what do you use when you're already working on a retrograde case? You're trying to stent all the way to the ostium. How do you decide where is your stent going to be? And you're not going to use any antegrade injection to tell you where your ostium is. What tricks do you use to be sure that you're covering the ostium?
Well, one thing is when you pull the stent out and you put in the ostium, you see it suddenly flips out. That means you're very close to the ostium. There's a feel of it angiographically when you're at the ostium or not. So I don't know if you noticed that sometimes when you position the stent at the ostium, you just pull it back, you see it be a little bit of a lift. When that lift happens, that you're very much covering the ostium, but not too much. I think Colin, you have a better way to explain than I did?
No, you're very elegant, but if your stent is like that, the ostium, you're missing the ostium.
Yes.
And this is what you're referring to, isn't it?
Yes.
It's pointing up. Once you see the proximal end of the stent lifting up, you're right at the ostium.
Correct.
So you just basically rely on position and expectation.
If it's like this, if it's at right angles, you're in too far. You need it pulled back, and of course it's very difficult to do that with an AL. you know, because the AL's either all out or
I think
all in.
column, this shows it.
Yeah.
Hang on.
See the
Here you've got some contrast in the cusp that makes it.
yes.
Yeah, but assuming you don't see the contrast.
But look at
Yeah.
the alignment of the
Look
stand.
at the alignment.
See the stand?
Yeah.
You know that's right at it. If that was not lifting up, you've missed it. But it's very subtle.
Yeah.
But I think you're better putting the stent into the aorta. How do you so let's say for example this stent is now here and it's 5 millimeters into the aorta. How do you solve that scenario?
It's inflated already.
Yeah.
This is very important. This is really a very important question. Can you put the lights on, please?
Okay.
First
So
balloon is an option or not?
pardon?
First balloon is an option or
No.
not? So why having it all?
No. As long as you've got a wire, you can sort it. Hi.
You go below it and you wire through the struts.
No, the wire's still in.
And the wire is there?
Yeah.
Just use an.
Just clear it.
Flirt, okay, you can flirt, yep.
You have a wire that's already in the vessel.
Yeah.
So, put the balloon down.
Yep.
Over that wire. And then what? What do you think? What's the next step? That's one hint.
Pull the guide back and then
The stent would fly out.
Don't pull it back.
I mean, you have
Push
a
it in. So if you hit the front end of here with a 7 French guide and an anchored balloon, what's going to happen in the stent? Crushed. Yep. So you just smash the stent.
Yeah.
Where do you keep the balloon? In those two?
No, round the corner. Let's flop forward. and
Inside the vessel.
But it will not be crushed, the whole circumference, just part of the circumference will be
Yeah, but you shorten it. Just shorten the stent.
from one side.
All sides. All sides.
And the balloon is inflated inside
Yep.
the stand.
So the balloon is inflated in here, and you just keep on pulling and pushing.
So you rotate the guide
Yep,
to make
push
sure
it
that
down.
everything is,
Yeah, push it down, hit it again.
and then rotate it and then,
Damaging the stent's not the issue. Once you hit it a few times, it's
yeah,
what you have to do on the way out
is to make sure that you,
is to reinflate.
yeah,
Yeah.
yeah.
Colin, once I thought of this as well, I thought, you have the wire in the balloon, like that, and then you take say it's a 3 millimeter stent, so you put a 3 millimeter without, 3 millimeter balloon, without the wire on the guide,
Yeah.
and half of it is out,
Yes.
and you just,
I just hit it.
and then hit it.
As long as you got your wire down the center of it.
So you understand this, the second way you can do it as well? Yeah, but we did with these cases.
If you leave it hanging, it's a source. I've seen a stent thrombosis, and then the patient came back unwell, and the operator had real difficulty trying to solve it because you're in and out of. Yeah.
So what is the maximum length to leave? How many struts?
Okay.
Can go outside.
I know. You can go 48 millimeters outside the ostium. You shouldn't, but you can.
So he's asking what the maximum that you really need.
How many steps do you step?
Oh yeah, so you're trying to go a millimeter or two out. And if a millimeter or two, 1 millimeter ideally. So here you just want a millimeter, and then you post dilate it and flare it is what you really want. But let's say for example he takes a big deep breath in, and you're doing a radial procedure. The guide gets lifted up, the stent is here. And that is a disaster, but you can sort it as long as you've got your wire and your balloon still there, and you just keep hitting the front end of the stent, and you will shorten it.
My damages.
Oh, it'll severely damage it, yep. It'll really damage it, yep.
And this is not as part of future events.
No, as long as you do that post-dilation. I've seen stents struck off in the left main stem where we've had to drill them, drill the stent out, so you can do things like that. But if this is out 3-4 millimeters and you hit it with a balloon, it's fine. That's what we do in a crush all the time. That's what we do in any bifurcation.